Hello, everyone, and welcome to episode 11 of CCLG's Research Talks for Parents and Public. I'm Ellie Ellicott, and my job is to share research with our supporters. So, starting with some housekeeping, we'll be holding a Q&A session at the end of the talk, so please do submit your questions whenever you think of one using the Q&A button that is at the bottom of your screen. If you'd like to use the chat function, make sure you set the to drop down to everyone, or people might not see your message. The webinar is being recorded and will be available publicly on our YouTube channel, and we'll send out a link when it's ready to watch, which will likely be next week. So this month's talk is called What Can Patients' Blood Tell Us About Wilms Tumour, and is being led by Professor Matthew Murray. Matthew is a professor at the University of Cambridge and treats children with cancer at Cambridge University Hospital's NHS Foundation Trust as an honorary consultant. He's interested in the molecular side of childhood cancer, and his research has shown that tiny molecules found in the blood can help diagnose and monitor some types of cancer. So, without any further ado, I'm going to hand over to Matthew.
So thank you very much for inviting me to talk, and thank you to everyone for giving up their time to listen. If I share my screen, and hopefully can start that from the beginning. So is that projecting okay?
Yep, looks perfect.
Okay, so thanks again. So yes, this is going to be a talk today about what we can learn from patients with Wilms tumour in their blood. And this is very much led from other work that we've been doing in childhood tumours. So in terms of conflicts of interest, I've got nothing I need to declare. So one of the privileges of the job that I do is that I have the benefit of being able to work 50% of the time in the clinic, which is based at Addenbrooke's Hospital in Cambridge, one of the 20 principal treatment centres in the UK. And I spend my other half of the time doing research, which for me is based at the Department of Pathology in the University of Cambridge. And that really means that in the clinic, we can think of questions that are important to us when looking after children with cancer. We can try and find ways of learning more about what underpins these tumours, do molecular testing, and then try and find ways of bringing that back to the clinic to benefit patients. So it's a privileged job, and it's a job that's different every day, and one that I still and continue to be thoroughly enthusiastic about. And this is what we're aiming to do. We're aiming to take basic research findings from either tumours themselves or from samples taken from patients, be that blood samples or spinal fluid samples for patients with brain tumours, for example. Make really sort of fundamental findings, work out what's driving these tumours, work out whether we can use these findings to improve treatments, or find new blood tests and biomarkers which are we can use to diagnose patients, to follow them during treatment and into follow-up. And really the aim of all of this is just trying to improve patient health and translating that new knowledge into clinical practice. So in terms of what patients' blood can tell us, there's lots of information. I mean, the blood is a real sort of soup and a gold mine of information that we can learn from. So it contains blood cells, which we would routinely measure. I'm sure many of you are aware that you can order an FBC or a full blood count. We can measure levels of salts and enzymes in the blood. So that's what people refer to as U's and E's and LFTs when they measure those results. So they're very standard routine tests that are in clinical practice. The blood is also made up of the things that we eat and they sort of get absorbed and then transported around the body and are made into other building blocks for other things such as proteins, carbohydrates, lipids, and fats. So there are proteins that occur in the bloodstream, and we can use those. Those are some existing tumour markers that we can use in the clinic for some tumours. I think there's also interest in the research side of looking into carbohydrates and lipids and fats to see whether they can give us signals to do with disease, be that certain pathologies, including cancer. In adult oncology practice, there is some research interest in circulating tumour cells. So can we actually detect cells circulating around the bloodstream? That might indicate they're moving from a primary site, the original site where the tumour arises, to other secondary or metastatic sites. They are difficult to detect, and the significance at the moment, the clinical significance of that remains to be determined. And then we get on to sort of the genetic code the sort of the building blocks of our genetic code. So there's DNA, and there's certainly interest in looking in, particularly again in adult tumours where patients build up, they get changes in their genes over time, and they are often multiple and sequential. That there's interest in looking at circulating tumour DNA and bloodstream of particularly adult patients. And then the message which the RNA produces is often called RNA, and there is some interest in that, although there's real challenges in measuring that in the bloodstream because it's not very stable and it tends to get broken down into lots of very short pieces of RNA that aren't very informative. And finally, this is going to be the subject of what I'll be talking about today, is microRNA. So as the name suggests, micro, they are very, very short, small pieces of genetic code. They don't actually code for proteins, but they actually regulate messenger RNAs. And I'm just going to show that in the next diagram as to how that works. So DNA is our building blocks, is the genetic code on the left. That then in the cell would be passed on to make messenger RNA, which literally carries the message for the protein. And then the protein is the things that if you have abnormally high or low levels of certain proteins, that can cause cancers to occur. And microRNAs act at this point, so they're little short pieces of genetic code that interfere with the processing of RNA into protein. So in itself, abnormal levels of these microRNAs can potentially cause cancer. So we worked on this is sort of many years ago, and I started working in a tumour called germ cell tumours. They occur in childhood, but also occur in adulthood. And we worked with the CCLG, so we got approval through a research project to study children's germ cell tumours. And we had a number of tumour types and of these germ cell tumour types, and then what we call profiled them to look for hundreds and hundreds of these little microRNAs, these tiny short pieces of genetic code. And what we produced is this picture here, which is called a heat map, with things which are high levels being hot, being red, and things which are at low levels being, or cold, being shown in blue. So there's a couple of key points here. Each of these, can you see my cursor here? Yeah, so each of these individual little lines here represents a patient sample. And each of these little lines here represents an individual microRNA, and they're called MER, and then they're called by a number, and they're numbered from about 1 to a number of thousand. So the first thing to say is that this at the top shows how similar samples are to each other. And what we found was there are two branches. There's a branch on the left, which is all the malignant samples, and there's a branch on the right, which is all the non-malignant samples. So in short, we could tell, using this microRNA profiling, we could separate all the malignant tumours from the non-malignant tumours and control samples. So that was a really important finding. And the second thing we found was that there was, shown here by red and white, there were very, very high levels of a small number of microRNAs from two clusters. And this is the numbers these are assigned, but it's MER 371 to 373 cluster, and the MER 302 and 367 cluster. So that's the name of the specific sequences of these short pieces of genetic code. And these microRNAs, in fact, in non-malignant tumours, of these germ cell tumours and control samples, are virtually undetectable, shown here by this very dark blue. So we took these 8 microRNAs from these two clusters, and we looked to see whether they were able to separate the malignant from non-malignant tumours in more detail. And the answer to that question is yes, they could. So we've got childhood tumours, germ cell tumours on the left, and we have adult tumours on the right, which we analysed as well. And listed here are these 8 different microRNAs. And we found that there's this map at the top segregates the samples into 2 branches, both here and here in adults. So these tumours are completely segregated by the signature of 8 microRNAs. And this finding, so that's the segregation of these samples. So very high levels in the tumours, very, very low levels in non-malignant tumours and control samples. And this was the first sort of universal finding, molecular abnormality in these tumours. And it's regardless of patient age, be they children or adults, regardless of tumour site. So these tumours typically arise in the ovaries or testes, but also arise at other, what we call extragonadal sites outside the gonads, which include the brain, and also regardless of the different malignant subtypes. And the names aren't important, but there's 3 main different malignant subtypes. So this was the first common abnormality. And because it was so specific, we didn't find that signature in any other tumor type or any other disease state. So one of the things we thought about was actually if these tumors are producing high levels of these microRNAs, we hypothesized, we had this, the idea that maybe they're releasing these levels of these microRNAs, they would be released into the bloodstream in patients. And if we took a blood sample, maybe we could detect them at high levels too. And this could potentially be used as a marker. And so this was, again, this is sort of well over a decade ago now. We had a patient presenting to us in Cambridge who presented with this large mass shown on this scan here. And they, in fact, did have this patient had a biopsy and it was a malignant germ cell tumor, and they went on to have successful treatment. But at the time of diagnosis, we measured the levels of these microRNAs in the bloodstream, and you can see the levels are shown here. So the levels were high, and the levels of MER3713 microRNAs, which are shown in red, were particularly high. So here is MER372, and that level was over 700-fold higher than in patients who had normal, who were from normal patient blood. So what this suggested to us was that this microRNA would be a really, could potentially be a good marker. And what we showed over the course of this patient's treatment and then surgery was that the level fell in the bloodstream and remained normal. This patient's tumor shrunk to something the size of a golf ball. It was then resected. It was under the microscope. It was completely dead. It was necrotic. There was no live tissue. And consistent with those findings, the levels were normal and remained well, and the patient remains well in uneventful clinical follow-up. So that was the first. We'd shown it was in these microRNAs were present in the tumors at high levels, and then we've shown it was present in patient bloodstream. And this is just another example, and the work has really narrowed this down to one microRNA marker, particularly MER371. And this is a patient who presented to us in Cambridge, again with a testicular cancer, this type of germ cell tumor, and they had the testis removed, and the scan at that time showed it was just restricted to the testis, so it was a stage 1 disease. So this is a picture of their tummy, which doesn't show any evidence of disease spread. And once the tumor had been removed, the level of this microRNA fell rapidly. But then over the next couple of weeks, we found that the microRNA level in the bloodstream went up to 100, and then 5 days later was up at over 200. So it was increasing rapidly in early clinical follow-up. And a scan done at this time of the abdomen showed that the lymph nodes, which is where the testis cancer often drains to, this is all shades of grey, but for radiologists, the X-ray doctors who look at these regularly, this is an area where the lymph nodes have enlarged. And this is consistent with further disease. And so the patient received 3 courses of chemotherapy. The level of microRNA fell very rapidly to normal. And then again, with this patient, the end of treatment scan showed no evidence of disease, and the microRNA level remained normal in uneventful clinical follow-up. So what this showed was that this microRNA in the bloodstream could be used for diagnosis, could be used for early disease monitoring to see whether the treatment, which in this case was surgery, was effective. It showed early on evidence of disease recurrence, which was treated with chemotherapy with a good disease response, both on the blood test and on the scan. And then in long-term uneventful clinical follow-up, this patient remains completely well. And just as an aside, this isn't just restricted to the tumours outside the brain. These germ cell tumours in the brain, when we look at the spinal fluid levels, each of these 3 pictures shows a tumour in the centre of the brain. These 2 are malignant germ cell tumours shown in black and grey. And this was a benign glioma, or a different type of tumour here, but all in the same region of the brain. And when we look at the spinal fluid levels of this MER371, we see that they're very, very high in the patient with the germ cell tumour, and they're very, very low in the patient with the benign glioma. And this is what we call a log 10 scale, so that it changes the numbers change very rapidly. So we've got a level close to 100, in fact, level close to 100,000 here, level just under 1,000 here, and this level in the glioma case is sort of virtually 0.001. So tens of thousands of fold higher in the spinal fluid. So this is a bit the sort of the sciencey bit. So I hope people can bear with me and stick with me here. So this is how we assess whether. So I mean, I've shown you clinically, hopefully, that in a small number of cases that we looked at these patients, that this marker could potentially be useful. But the formal way of looking at it is something called a receiver operator characteristic curve, or ROC curve, and this tells us how good it is at picking up patients with disease, i.e. the true positive rate, and how good it is avoiding picking up people who don't have the disease. So you really don't, you want your test to pick up all the patients who have the disease in question, and you want your test to pick up no one who doesn't have it. And that's reflected by this true positive rate and the false positive rate, and these are on these two axes here. So if your test is only as good as tossing a coin to tell you whether you have the disease, sort of a 50-50, then your curve just goes up this, it says here, random classifier, just is this dotted line here. And as your test becomes more sensitive and more specific in picking the right people out as having the disease, then you get a curve on this line, which increasingly sort of gets the area under it gets bigger and bigger and bigger. So it's a better test. And the perfect classifier sits here at 1. So what that means is a perfect classifier means that you pick up everybody with the disease and you don't pick up anyone who doesn't. So the area under that curve, which is actually no longer a curve, but actually a square rectangle, is 1. So under this area here, where it's tossing a coin, would be 50% or 0.5. And this area here is 1. So when you're looking at a marker in the bloodstream, you are looking for an AUC, an area under the curve, which is as close to 1 as possible. So if it's 0.5, just remember that's like tossing a coin. If it's 1, that's the perfect test. So anything that's pushing on above 0.8 towards 0.9 and above is a good test. And this is just an example from a German group who work in germ cell tumours, and this is the ROC curve for germ cell tumours for MER371. I think you can see from this dotted line here, this is the 50-50 line, and for different types of germ cell tumour at different stages. So stage 1 is the lowest stage. The area under this curve is 0.95, and for patients who have their disease has spread, clinical stage 2 and 3. The area under the curve is 0.996, and for all patients overall, it's around 0.966. So you can see this is reflected in these curves that are close to perfect, but not quite. But it's in clinical practice, we don't really have any test that is 100% perfect. So, but this is as pretty much as close as we can get. And as a result of this in germ cell tumors, with these very high AUC values, there have been now, from our studies which originated in Cambridge, this has been replicated by researchers all over the world. There's been more than 50 papers published in this area. Everybody agrees that MER371 is the test that we need to be doing for germ cell tumours. It's been shown in more than 3,000 patients worldwide, and part of that is because testis cancer is most common in young adults, and it's much more common than in numbers of cases we see in children. And as a result of all this, this is the sort of the way this is moving towards the clinic. And so even with these very large numbers, it takes time for research to take place, and it takes, it sometimes feels like a very long time. And since our first discovery back in 2010-11, we've embedded this finding into clinical trials so we can test it out, see how effective it is. I mean, the key thing is we want to help patients, but we need to make sure it's safe, it's effective, that it's the right test at the right time, and we're not trying to run before we can walk. And as a result of those sort of timelines, and you can see the dates on this timeline here, this is just sort of the length of time that research takes. And when I started this project, I had a lot less grey hair than I do now. So where we are now is that we've now got funding from NHS England, and over the next 2 years, so by 2026, initially found this in 2009, we aim to transfer this so this can be accepted into NHS clinical practice. So that's sort of just the timeline in germ cell tumours. And the reason for giving you that background is because a number of years ago, we thought, well, if we can apply this principle to germ cell tumours, can we apply this principle to other tumours of childhood? And this is where this small study we published in 2015 came in, which included patients with Wilms tumour. So one of the findings in this is we included a whole range of children's tumours, and one of the things we included was neuroblastoma. And just looking at this child's tummy here, we can see here's the kidneys on both sides as in this schematic, which is where Wilms tumour arises. And neuroblastoma tends to arise as an abdominal mass just above the kidneys. And one of the things just with neuroblastoma is that we want to know whether patients have this genetic change, which we call MICN amplification, because patients' survival tends to be worse if they do have it, and we know we need to give more aggressive treatment. And this is the heat map that we got from the bloodstream in children from their blood with a variety of different cancers, and the Wilms tumour or WT cases are here, and I'll come back to that in a minute. But what you can see is blue is cold and red is hot. So for neuroblastoma, we see a very, very high levels of micronase in the bloodstream. And I think one of the important things to say is that with children, when children present, sometimes the amount of tumour that they have relative to their body weight is relatively high compared maybe with adults presenting with a small tumour. And that means that the signatures that we get in the bloodstream are often quite strong. And so in fact, in this study, there were only 2 children in this MIC-N group, shown here on the left. And in the standard neuroblastoma group, there were only 2 children, but we still got these strong signatures. And the reason I'm going to highlight this is just again, I'm just going to highlight 3 micronase, which is 124, 218, and 490, which were 3 out of the 5 that we found. And the reason for highlighting those is a couple of years later, there was a published European study of 200 children with neuroblastoma. And in fact, what they found is in patients with metastatic neuroblastoma that spread, and most of those are due to this MIC-N amplification, these MIC-N cases, that the levels of these 3 micronase shown here in red are very, very high in the metastatic cases compared with patients with localized disease. So what we've shown is in a very, very small study of the bloodstream, with just 2 versus 2 patients, we've identified 3 micronase that in a very large study of 200 patients has been shown to be the case. There's a lot of interest in looking at these micronase for helping diagnose neuroblastoma patients and also in predicting response to treatment. So Wilms tumour. So Wilms tumour is obviously, as many people will know, is also called nephroblastoma. Patients typically present with abdominal distension that can be painless, but they can also present with abdominal discomfort and blood in the urine. 5% of all paediatric cancers. So in the UK, that equates to about 80 or 90 children being diagnosed. Typically young children 1 to 10 years of age, with the peak 3 to 4 years of age. And for Wilms tumour, the outcomes are generally good, with 90% for localized disease and still 75% for children with metastatic disease. And this is just a typical sort of abdominal CT scan of patient who presents. So what we see here is a sort of cross section. So we see one of the slice through the kidney, which is a normal kidney, this is on the left side of the patient, and then on the on this side over here, we see this is the kidney tissue here, and it's sort of been splayed open by the tumour, and the tumour we see is this area here. And this is what radiologists typically call a crab claw sign, because the kidney is opened up and it has this central area, which is like the crab's body, and then the claws either side. And that's quite a classical feature for Wilms tumour. So in terms of numbers, the most common childhood cancer is leukemia, and solid tumours, brain and spinal tumours, but kidney tumours, there's sort of 80 to 90 children per year in the UK is represented here. In terms of outcomes, the average survival for all children's cancer types combined is currently sitting at around 84%. So kidney tumours are here. So they, generally patients with kidney tumours have a good outcome, but there's still a number of patients, there's a gap here. We're trying to do, what we can to improve treatment and diagnosis for all patients and follow up for all of those who survive, but also try and identify patients who may need further treatment more rapidly and identify better treatments. So what the current issues are there for Wilms tumour, there is no current standard blood or urine biomarker that we use. We do need in diagnosis and treatment 3-dimensional imaging with CT and MRI, and for most, as I say, these young children, so they need IV and oral contrast and often sedation or general anaesthetic. We can avoid, in Europe, we can avoid surgical biopsy in some patients, depending on whether they present with typical age, usually 1 to 10 years. A typical presentation, the imaging signs, such as the one I've shown you, in which case preoperative chemotherapy is given, and then we confirm Wilms tumour on the resection of the tumour. There can be some difficulty in diagnosing kidney from other abdominal tumours, for example, so sometimes it can be difficult to distinguish from neuroblastoma. One of the things is that most of the Wilms tumour patients who recur and relapse are not necessarily in just the highest risk groups, because most patients fall into the other groups, such as the intermediate risk group. Then those patients still represent a number of patients who will go on and have further disease, and it's difficult to identify those. And so a sort of a simpler, more accurate diagnosis and disease monitoring for this tumour type is an unmet clinical need. And this is just to show that between 1 and 10 years of age, and I apologize because this is slightly blurry, but here's 1 year of age here, 10 years of age is here. And so most patients with a renal tumour between 1 and 10, by far and away, Wilms tumour is the most likely, with the other tumours being much, much less frequent. And then after 10, this level of Wilms tumour starts to come down and the other tumours become more prominent. And again, under 1 year of age, Wilms tumour is less frequent and some of the other tumours are more common. So this is why the European group have adopted 1 to 10 years as being, with all the other features which are consistent, just going ahead with the biopsy, without a biopsy and treating. And then the other thing to say is that obviously preoperative chemotherapy followed by surgical resection, which is typically nephrectomy. And then post-operative treatment depends on risk, and that's based on what it looks like under the microscope or histology and stage. That's then chemotherapy plus minus radiotherapy. And there are issues at looking at under the microscope because a lot of the determination of treatment depends on how much percentage of different types of the Wilms tumour is left. And obviously, if you have a very large tumour to start with, then a small percentage of a large tumour is still quite a lot of tumour volume. So it's very difficult. And up until recently, it's not been an exact science. And the umbrella group, which is the group that is trying to improve outcomes for children with renal tumours, are working really hard to improve pathological reporting and define it really carefully so we can identify the best treatments, really sort of personalised medicine for children. And this is what these tumours look like under a microscope. And the classic appearance is what we call triphasic. Triphasic meaning 3 phases or 3 types. And these are blastemal type, epithelial type, and these are the tubules which represent sort of, the kidney tubules which do the function of the kidney, and stromal type, which is the stromal tissue is the supporting tissue of the kidney which holds everything together. So a classic triphasic tumour will have all these elements, but sometimes they just have one element, and sometimes they may be called anaplastic, which means you can't really tell the origin of these cells at all. So the pathology is very, very complicated, and I don't pretend to understand it all because Wilms tumour is not my sort of expert area. What I'm doing is translating some of the blood findings from other tumours into this tumour type. And this is the heat map we found in our original paper for Wilms tumour. And one of the things it highlights, if you think of the very bright red, hot, high levels of microRNAs in other tumour types, what we have for Wilms tumours, we'd identified 6 microRNAs which are listed here, but they're sort of a deep salmon colour, but they're not necessarily completely unique to this tumour type. And you see a lot of pink in some of the other tumour types. So what we know about, and as I say, so this it didn't stand out to us with a really obviously clear signature in the bloodstream. And that's probably because these tumors are very, very different, different from each other. And if you look at the samples we looked at, these, as you say, some of them have triphasic, this classic histology. Some of them just have one type of the tumor I showed you previously, and others don't have a tumor type that doesn't really resemble the kidney at all. So that variability in the clinical samples reflects the variability in some of these microRNAs, and the fact that we only looked at 6 patients in the study, so it's a relatively small number. So in some tumours, you get a really clear signature with just a small number of patients, but in this tumour type, we felt we needed to look at more children with this disease. And that's where we worked with Kathy Pritchard-Jones, Tanzina Chowdhury, and Reem El-Saidi, who work with the Umbrella Group. And with funding that they had obtained, we looked at blood from 38 Wilms tumour patients and 9 control patients. And this is a bit of a boring flow sheet, but what it tells us is we looked at 750 different microRNAs at the start, and then we worked through this flow sheet to find ones which were very high levels in patients with these Wilms tumours. And all of these filtering steps, we ended up taking away microRNAs. So we were trying to get a relatively small list of microRNAs we could test in more detail. So for this, we used these filtering steps I've mentioned here. We used this area under the curve, the AUC value on the receiver operator characteristic curve of more than 0.9, meaning we think that's potentially a good test. And we also looked for ones that the levels were high compared with control patients. So we're trying to find the ones which have got the highest levels and are quite discriminating. And this is just a little pitch of the, we've picked up 12 or 15 of these, and these are the plots that we got. And what we, again, we're trying to do with these plots, the Wilms tumour patients are the red dots and the control patients are the green dots. And we're trying to sort of find clear daylight between those two samples in terms of the levels in the bloodstream. So you can see that with some of them, there isn't a complete daylight between them. And as a result, the AUC value isn't necessarily 1. And I'm going to show just a couple of these in bigger detail because these are quite small plots. So when we look at the levels, bizarrely, just to say bizarrely, the lower levels are at the top and the high levels at the bottom. So that seems a bit counterintuitive, but these are control patients where essentially we can't detect levels really in the bloodstream. They're at very low levels. And you can see this dotted line can distinguish all of the patients apart from one in each of these different microRNAs we were testing. And as a result of that, the area under the curve is close to 1, but not completely 1. But what I would say is that this is a relatively, 38 patients is still a relatively small number of patients. So what we've gone on to do is do further PCR testing in the laboratory, and we're looking at producing ROC curves for all of these different individual microRNAs, and we can see that, again, these areas under the curve are variable. These are the individual microRNAs. And then we've looked at all 15 together, a panel of 15. And what we do see for that panel is that we can get an area under the curve of 1 where we can distinguish all the patients with Wilms tumour from those who don't. So that's, it shows that this is, promising for this disease. So what we've done to date with the umbrella team is using this original grant that was through the CCLG. We've done this discovery study. We've gone back and tested it in the discovery study to see how it's performing. And what's absolutely critical in this situation with this type of research work is to say, we've done this in this discovery group. We've got a panel of microRNAs that we think is promising. Can we now take that and test it in a new independent group? And it's not always this case that it always behaves exactly the same. So because the groups will be different, there'll be slightly differences in terms of the histologies between the different groups, and different factors of different ages and different stages. Some of these tumours may be, in this new group may be smaller than the group we had before. So there are differences, and it's very important when you've done a discovery study to make sure that applies to a validation study. And that's really the first step on that road. Like I showed you in germ cell tumours, we started with one single case study in 2011, and over time we've built up the numbers to over 3,000, and we keep finding the same thing, which reassures us we're on the right lines, because we may need to go back and make further refinements to this panel, having done this validation. So to summarize where we are with this, and it's a lot of, it's slow and painstaking work to make sure we're collecting the right things. So there isn't a blood or urine marker currently. It would be helpful for diagnosis, disease, monitoring, follow-up. From this global study in patients with Wilms tumour, we started looking at 750 common blood-based microRNAs. So that's a large proportion of the ones, we're likely to, if there are microRNAs that are useful, we're likely to pick them up. We've narrowed that down to a really strong candidate panel of 15 in our discovery group. And we've confirmed the ability of the panel with further PCR testing, which we would be doing if we were transferring it as a sort of clinical test. So we've changed to a different type of PCR testing and confirmed that panel is useful. But this is the really big next step, and it's ongoing work, which is how that panel performs in a larger group, which may need further going back and reviewing and taking some of those microRNAs out and adding new ones in, and refinement. And obviously our ultimate aim is to develop a test that could be used in routine NHS practice. But if you looked at the timeline in malignant germ cell tumours where there's only a single microRNA and it's actually very clear cut, you can see that the timelines are such that this is, realistically, even with a lot of concerted effort by research teams, will be 5 or 10 years away. And we're working on this with the umbrella team in the UK. I know there's a German group working in a similar sort of research area, and I think our plan is to move this work forward and publish it, and then liaise with the German team and make, if necessary, combine our data sets to get the strongest panel for the diagnosis of Wilms tumour. So in terms of acknowledgements, in the Cambridge laboratory, the people who are fundamental to doing this work are Dr. Cinzia Scarpini, who's our senior research associate, and she's shown there in the picture on the left. and Dawn Ward, who's our senior technician, who've been fantastic in taking, the samples, extracting the RNA and running all these tests on these samples, which have been very kindly provided by people as part of CCLG studies and the umbrella protocol. And obviously, I'd like to thank the umbrella protocol team, which includes Kathy Pritchard-Jones, Tanzina Chowdhury, and Reem El Saidi, and obviously very much to the Children's Cancer and Leukemia Group and the funding groups who've so generously donated their funds to help support this and other projects. So I'd like to thank everyone for their attention. Thank you for bearing with me. I hope at least some of it made sense, and I'll stop for questions.
Okay, so yeah, that was really interesting, and it's really amazing on those graphs to see that just solid line going down between the two expression amounts. So we had one question in, but I think you answered it. Did you want to stop sharing your screen, Corey?
Yeah, that's fine.
So I did write questions down while you were talking because my brain was just going off one. So I was going to ask, are you finding that the germ cell tumour work is progressing faster than in Wilms? Because it's also in older ages? I don't know if that makes a difference.
So I think it's a really good question. I think there's a number of factors. So firstly, in pediatrics, germ cell tumours account for about 40 children per year have a germ cell tumour, but in adult practice, it's about 2,400. So interesting. So I mean, one of the things which accelerates this testing into clinical practice is to get companies involved who might be interested in sort of making kits or producing, and getting involved that way. So interestingly, we worked with a number of different groups. We did actually work with germ cell tumours with AstraZeneca for a period of time and published a collaborative paper with them to try and move it forward. But interestingly, despite that, so what I would say there has been for germ cell tumours, there was virtually no commercial interest in adopting it as a clinical test. And that is despite there being in total, if you include adults and you include children with this disease, we are probably talking 2,500 patients per year. And in each of those patients who has a diagnosis, we'll probably run 20 tests. So we are probably, so I mean, companies are interested in units. So we were saying to them, we would need 50,000 units a year in the UK. And they just said, that's nothing, that's not enough. So in Wilms tumour, when we have 80 or 90 patients in the UK per year, and even if you're monitoring it over a period of time and running 20 tests, those sort of numbers are not numbers that interest companies. And so it's just, so it's difficult. And so one of the things we have to consider is whether so in some of these microRNAs, I haven't specifically given what for published data, I've said what the microRNAs are, but for some of this data, we haven't specifically said what the microRNAs are, because one way of trying to accelerate it to patient benefit is to sort of ask to try and get intellectual property on it, which then you can use to interest a company to try and get it accelerated. So one of the things we didn't do with germ cell tumours, we took advice from Cancer Research and a number of other different agencies, and they said, oh, you should just go and publish this. So once we'd published it, they said, well, what's your IP, what's your intellectual property? Once we didn't have any, there wasn't. So that's really interesting, because you think, well, I have no interest, as I say, I've got no conflicts of interest. I have no interest in anything, I've got no shares in any companies that, do you know what I mean? And so all I want to do is get these tests into the clinic. But interestingly, it's challenging with relatively low numbers and without intellectual property to get company interested to make it. So that's what I'd sort of sum that. So I would think that with dedicated research, we will be looking at, that's why those timeframes are the most likely realistic.
Okay, so we've had a question which follows on from that.
Yeah.
It says, you mentioned that 80 to 90 are not numbers that are interesting for a company. So what basis is that on? Is that to research or?
No, so in research, for pure research, that is, children's charities, so it's all the one named funds for the children cancer leukemia group, that it's numbers like 80 or 90 children per year is not that's not taken into consideration. Do you see what I mean? Because there are lots of small children's charities. There's Little Princess Trust, Children with Cancer UK, all the named funds through CCLG who are only interested in children's cancer. The difficulty is it's not interested for big pharmaceutical companies, and that's an ongoing problem with access to drugs and trials and things, making sure children's voices are heard. So that's a more generic question. So I mean, we just have to advocate, as interested parties all the time for children and for children with cancer specifically. So that's, so we will continue working with the Wilms tumour experts and the renal tumour experts to do that. So that's the difficulty. It's just the numbers don't add up to anything that's commercially interesting to companies.
Okay, so got a follow-on question from that. So basically, are you saying that it means it's not profitable for those companies to make those medicines or tests?
Quite often, and so that's a challenge that we need to make sure we're in those conversations all the time, and discussing things with companies about the possibilities. But it doesn't mean, so for germ cell tumours, we are in the process of moving this test from a research setting to a hospital lab accredited setting. So it just means you just have to be more determined than ever, and just make sure you just keep pushing with getting this onto sort of the the agenda and getting done. But it doesn't mean there's not the interest there. So there are quite a lot of questions. So I'm going to so can this research be implemented in hospitals as routine check when having bloods? Not at present, but our aim is that in a period of time it will be. We're looking in blood, and we wonder also in the future whether these, because they're kidney tumours, they may be just released into the urine. And so it might be that we can actually do a simple urine test and look for evidence of levels going up in the urine as an early indicator. So that's something else we're interested in, because that's even easier than doing a blood test. So when is it likely to be? It is probably at least 5 or 10 years away. So that's that. And then, so is renal cancer different to Wilms tumour? So renal cancer is an umbrella term that includes a number of things, including Wilms tumour. It includes renal cell carcinoma, which is RCC. It includes malignant rhabdoid tumour of the kidney, which is MRTK. There's clear cell sarcoma of the kidney, which is CCSK. There's mesoblastic nephroma, congenital mesoblastic nephroma, or CMN, which is a benign tumour in younger infants. So there are quite a few other different kidney tumours in children. Wilms tumour, as I showed you on that graph, a bit blurry graph, but the red dots at the top, by far and the most common in childhood, particularly between 1 and 10, and the others make up a small percentage. But it will also be important to check that these profiles will distinguish Wilms tumour from other of the rarer subtypes. And of course, over time, we hope we'll be able to look and identify, that the umbrella team will be able to identify markers either in the blood or the urine, or in those other rarer renal cancer types in children. And it says here, why is it a different name in younger ages? So it's just, I mean, it can be called nephroblastoma or Wilms tumour, and they're interchangeable. They mean the same thing. So we don't tend to use different, we don't try and use different terms, although there's a lot of medical jargon flying around. So that's that. But there are different types of, so congenital mesoblastic nephroma is a different entity to Wilms tumour. So that's that question. And then someone's commented very rightly, for germ cell tumours, AFP and HCG tumour markers are used. So how useful or easy is it to use microRNA to monitor disease? So in children, AFP and HCG, so AFP particularly in children's germ cell tumours is a marker. Again, it's a bloodstream protein marker. They are established markers and have been since the 1970s. They are more useful in children than in adults. So in children, most children with a malignant germ cell tumour will have a rise in AFP. So that's a useful marker to detect. But in adult practice, where most patients present with a testicular germ cell tumour, AFP and HCG markers are only positive in about half of patients. And for that means that those patients, once they've had their testis removed, because most patients are stage 1, they will have, because the markers are not helpful and clinical examination is not helpful to detect those lymph nodes at the back of the tummy in that scan I showed, patients have CT after CT after CT after CT after CT, and many patients will have 20 CT scans. And we if we need to do all the CT scans, that's fine, but we are trying to reduce those. And so for germ cell tumours, the role of it, you said how easy is it to use to monitor disease? Our aim in a number of years, once we've tried to get into NHS clinical practice, will be that patients will have their microRNA level monitored, and if it goes up in follow-up, and then you repeat it again, it's gone up again, they would then have a scan at that stage, and it would save them all the CT follow-up. So that's a great question. And just looking at other questions. So there's a question here, with larger tumours that have had pre-op chemo followed by surgery, were you hinting that there might be a difference in the local stage from what's currently being given? So I think the rationale in Europe is to give pre-op chemo and then do a delayed nephrectomy, whereas in the US, it's typically an upfront nephrectomy. And the rationale of the European group, and they've got good evidence for this, if you do delayed nephrectomy in a cohort of patients, then a proportion of those patients will be downstaged. What that means is instead of being stage 3, they may only be stage 2, or instead of stage 2 may only be stage 1 when the tumour is resected. And one of the advantages of downstaging a proportion of patients, so maybe out of 100 patients, if you give them all chemotherapy, you may downstage 15 patients. And that may mean that, for example, 15 patients avoid flank or abdominal radiotherapy, which if we can avoid it and just get away with the chemotherapy only approach after surgery, we feel that's beneficial. So it is difficult. And when the pathologists are examining the nephrectomy specimen, the kidney under the microscope, what started to be factored in the umbrella protocol is what the original size was and how much is left, and what, not just the percentages, but also actually now working out what's left in terms of, of cubic centimeters or mils and work it out in actual volume of residual disease rather than just percentages. So all the time, I know the umbrella team are trying to refine things to improve, to maintain cure rates, but with as little chemotherapy as possible, and really try and identify more accurately the patients who are sort of slightly higher risk and who probably need more intensive therapy, which, for most patients get 6 months of VA chemotherapy after nephrectomy, but some patients we identify who need a full year of more intensive chemotherapy. I hope that's answered that question.
So I think we do have one more question in the Q&A thing, if that's okay with you.
Yeah.
So Eleanor has asked, were relapsed Wilms cases included, and were there any differences in that group compared with those with primary diagnoses?
So that is a really, really good question. And the answer to the question is that part of the study was looking at to see something for diagnosis. The number of relapse patients and how many samples are routinely collected at relapse isn't as, the numbers aren't as high, which is good, but the numbers aren't as high, and not necessarily all the samples of blood and urine and everything have been collected again at that time of, it's much more sort of consistent at diagnosis. So I think our first aim is to detect a diagnostic panel. We would anticipate that, especially as we're using this, so we know that in germ cell tumours that MER371 level is very good for, if it goes up, it relapse, it goes up. And we would anticipate that of that panel of 15 at diagnosis, and we can then start looking at disease monitoring and checking of the panel, are there any key ones which are more likely to be present at relapse or could be prognostic? So it's a very good question. I think we're trying to it's a sort of question which is probably a little bit further down the line as the umbrella team continue to collect samples. So we're not quite there yet. We're still trying to get around to the diagnostic question and sort that out. And then we can look at longitudinal samples of, serial samples that have been collected in patients, and particularly, as you say, at relapse, to see whether we can identify whether any of these panels, it might be that, for example, 2 or 3 are not only diagnostic, but have some prognostic predictive capacity to tell us whether patients are more likely or not to relapse. But at the moment, we don't know the answer to that question.
Okay, so I think you've answered all of the questions. So I think I'm going to read my little end bit, if that's okay with you. So thank you very much to everyone for joining us this evening, and thank you, of course, to Matthew for your fantastic talk. So the talk has been recorded and we will be sending it out next week. So if you'd like to share it or watch it again, you'll get an email. You will also be receiving an email shortly asking for your feedback on today's talk. This is so we can make sure that our talks are the very best they can be. So please do take a couple of minutes to let us know what you thought. And yes, have a lovely evening and Easter, everyone.